ABG or arterial blood gas sampling is a medical procedure used to collect blood from an artery, typically the radial, brachial, or femoral artery, to assess oxygenation, acid-base balance, ventilation status and metabolic status. The radial artery is the preferred site for arterial blood gas sampling due to its superficial location, ease of palpation, and the presence of collateral circulation that ensures adequate blood supply to the hand even if the radial artery is compromised. If the radial artery is inaccessible or unsuitable, other arteries like the brachial artery or the femoral artery can be used. For newborns, samples may be taken from the baby's heel or the umbilical artery shortly after birth. Before sampling from the radial artery, an Allen's test is mandatory to assess the patency of the ulnar artery and ensure sufficient collateral blood flow to the hand in case the radial artery is compromised. To perform Allen's test, instruct the patient to repeatedly clench and unclench their fist approximately 5 to 10 times to exsanguinate the hand. Apply firm digital pressure with both thumbs to occlude both the radial and ulnar arteries simultaneously, confirming successful occlusion by observing blanching of the palm and fingers. While maintaining compression of the radial artery, release pressure on the ulnar artery and observe the return of color to the hand. If the hand quickly turns pink within 5 to 15 seconds after releasing the ulnar artery, the Allen's test is positive, meaning indicating sufficient collateral blood flow through the ulnar artery. If the hand remains pale or takes longer than 10 seconds to regain color after releasing the ulnar artery, the test is negative, meaning the ulnar artery cannot compensate if the radial artery is blocked or damaged. So a positive test indicates it is safe to proceed with radial artery procedures, while a negative test suggests alternative access sites should be considered. However, studies have shown that the Allen test has limited diagnostic validity, with a sensitivity of 77% and specificity of 93%. It fails to predict ischemic hand events after arterial puncture and has only 71.5% inter-observer agreement. Therefore, it is not a reliable screening tool for assessing collateral circulation or predicting hand ischemia. A modified version of Allen's test called Barbeau test or pulse oximetry-based Allen's test is more sensitive than the traditional Allen's test in evaluating collateral circulation. For this test, a pulse oximeter is placed on the patient's thumb or index finger, and the radial artery is compressed. The pulse oximetry waveform is analyzed for up to 2 minutes before and after compression. The Barbeau test classifies the waveform response into 4 types. Type A with no damping of pulse waveform before or after compression. Type B with damping with compression and normalization after releasing compression. Type C with complete loss of waveform with recovery within 2 minutes, and Type D with persistent loss of waveform. Types A, B, and C suggest adequate collateral circulation, making the patient suitable for transradial access. Type D waveform indicates poor collateral flow and is a contraindication due to the risk of hand ischemia. However, emerging evidence suggests a shift away from the Allen and Barbeau test towards more objective techniques such as Doppler ultrasound. Contraindications to ABG sampling can be grouped into absolute and relative contraindications. Absolute contraindications include performing ABG sampling at a site with local infection such as cellulitis or abscess, as this risks systemic spread of infection. Another absolute contraindication is the presence of an arteriovenous fistula or vascular graft in the target limb, as puncture can compromise vascular integrity. Limbs affected by severe peripheral vascular disease with absent pulses or critical ischemia should generally be avoided. Relative contraindications require careful risk-benefit assessment before proceeding. An abnormal Allen's test indicating inadequate collateral circulation contraindicates radial artery puncture due to ischemic risk. Patients with severe coagulopathy and thrombocytopenia or those receiving thrombolytics or anticoagulation therapy have increased bleeding risk. Anatomic distortion from scarring, hematomas or prior multiple punctures also constitutes a relative contraindication. In cases of hypotension or shock where peripheral pulses are non-palpable, alternative sites should be considered. Ultrasound guidance can mitigate many relative contraindications by enabling precise vessel localization, particularly in those with challenging anatomy. When no safe arterial access exists, a venous blood gas may serve as an acceptable alternative for most clinical purposes. Clinical meta-analyses and systematic reviews have generally supported the idea that venous blood gas analysis can be used as an alternative to arterial blood gas analysis, particularly when assessing acid-base status and carbon dioxide levels, but they also caution about its limitations, especially regarding oxygenation. As depicted in this table, venous blood gas measurements show a strong correlation with arterial blood gas for pH, carbon dioxide levels, bicarbonate levels, and lactate concentration. This makes venous sampling a clinically acceptable alternative for assessing acid-base balance, ventilatory status, and metabolic conditions in stable patients. However, venous blood gas is unreliable for evaluating oxygenation because the partial pressure of oxygen and oxygen saturation differ significantly from arterial values and show poor correlation. Begin by explaining the procedure to the patient and obtaining verbal consent. Check for any contraindications which we have discussed earlier and perform the Allen's test to ensure that the ulnar collateral is patent. Appropriate personal protective equipment including gloves, apron, and face mask should be worn during the procedure for infection control. Additionally, ensure that cleaning swabs, gauze, tape and an ABG sampling syringe is prepared. ABG sampling syringes, which vary between sites, are typically heparinized to prevent coagulation between sample collection and processing in the gas analyzer. If the syringe is not pre-heparinized, manually flush the syringe with 0.5 ml of 1:1000 heparin and fully eject it to avoid dilutional errors. Some syringes are self-filling, where the syringe is filled by the patient's blood pressure once the needle enters the artery, while others require the operator to withdraw the plunger to aspirate the sample. Position the patient's wrist in slight extension and supination using a rolled-up towel or pillow for support. Using your non-dominant hand to palpate and stabilize the radial artery between your index and middle fingers. With your dominant hand, insert the arterial sampling needle at the identified site at a 45-degree angle. Once arterial blood flow is confirmed either by self-filling of the syringe or a visible flashback, collect 1 to 2 milliliters of blood. Remove the needle and immediately apply firm pressure to the puncture site using a gauze pad to prevent bleeding. Finally, the syringe is immediately sealed to prevent air bubble introduction and gently rolled between the palms to evenly dissolve heparin and prevent clot formation. The sample is then immediately analyzed without delay. ABG errors can be grouped into pre-analytical, relating to collection and handling of sample, and analytical, resulting during the process of analysis. Pre-analytical errors can arise from improper sample collection, delayed processing or contamination. Analytical errors in blood gas analysis can occur due to temperature miscalibration. ABG analyzers are calibrated for analyzing samples at body temperature. Hypothermia falsely increases pH, decreases PaCO2 and raises PaO2, while hyperthermia lowers pH, increases PaCO2, and decreases PaO2 if the analyzer calibration is not corrected for the patient's actual body temperature. During sampling, air bubbles may be introduced into the sample, which can rapidly distort results by elevating the PaO2 as oxygen from ambient air enters the blood. The PaCO2 may also be lower due to the dilutional effect of the air bubbles. Immediate expulsion of bubbles, sealing the syringe, and early analysis prevents air bubbles from mixing with the blood. Excess liquid heparin dilutes the sample, artificially reducing bicarbonate, PaCO2, and electrolytes like potassium, while insufficient heparin causes clotting. The clotted sample can obstruct the analyzer, rendering the sample wasted. Pre-heparin-coated syringes or pre-flushing with a minimal heparin volume and ejecting it fully ensures proper anticoagulation without dilution. Drawing adequate blood, for example, at least 1 milliliter of blood for 2 milliliter syringe is recommended to prevent blood clot. Delay in processing can happen when the sample is kept at room temperature or when it is improperly chilled. At room temperature, ongoing metabolism by red and white blood cells decreases pH and PaO2 with documented PaO2 drops of 40% within 20 minutes. This also increases PaCO2, lactate and glucose consumption. Prompt analysis within minutes or proper storage in an ice slows this degradation. Improper chilling, such as storing samples in direct contact with ice, increases gas permeability in syringes leading to oxygen loss. This causes reduction in PaO2. So the sample should be kept upright in an ice slurry and not in direct contact with ice. Sample contamination from conditions like extreme leukocytosis falsely lowers PaO2 as white blood cells consume oxygen. In such cases, immediate analysis of the sample will prevent WBC consumption of oxygen. The change in PaO2 should be accounted for patient's blood WBC count. Venous admixture, often from accidental venous sampling, mimics respiratory failure with low PaO2 and high PaCO2. Confirming arterial pulsation during puncture and using ultrasound for difficult punctures in obese or hypotensive patients can mitigate this problem.